Welcome to the deep dive. Today, we're taking a close look at something that affects, well, a lot of us, pain in the foot and leg,
Mm-hmm.
and specifically how that persistent ache, maybe that burning feeling you might have, could actually be coming from your nerves.
Yeah, foot and leg pain is incredibly common, and figuring out the exact source can feel like a bit of a puzzle sometimes.
Totally.
We often jump to thinking, oh, it's muscles or tendons or bones. But as the sources for this deep dive really highlight, sometimes the problem lies with the body's electrical wiring system, the nerves themselves.
Exactly. So we've gathered a bunch of research and articles, including actually a really insightful piece from Podiatry Today back in 2016 called "When is Heel Pain Nerve Pain?"
Ah, yes. A good one.
Right. It all focuses on the nerves down there in the foot and leg and, well, how they can cause trouble.
Uh-huh.
So our mission today is pretty straightforward. Extract the most important insights from these sources to help you, our listener, maybe understand potential nerve-related causes of your foot or leg pain.
Yeah, and also how clinicians try to identify it and maybe explore some interesting treatment approaches discussed in the research.
Think of it as like a shortcut to being a bit more informed about whether your pain might have a nerve component.
Exactly. We'll look at the key nerves involved, what can, trigger nerve pain, how it's diagnosed.
And some newer ideas too, right? Like nerve flossing.
Yeah, we'll definitely get into that. It's pretty interesting stuff.
All right, let's jump in then. To really get what can go wrong, we probably need a quick tour of the nerves down there in your foot and lower leg.
Good idea.
The sources really seem to emphasize just how complex this area is.
Oh, it is. It really is. Down there, you've got several major nerve pathways running around. The big one people often talk about is the posterior tibial nerve.
Okay.
It travels down, sort of behind the inner ankle bone, and then it splits. It branches into the medial plantar nerve and the lateral plantar nerve right on the bottom of your foot.
Kind of like the main power cable splitting off, you mean?
Precisely. Good analogy. And then you also have others like the sural nerve, the superficial fibular nerve, and the deep fibular nerve. They all run down different parts of the leg and foot.
And their basic job, what are they doing?
They're essentially communication lines, super important ones. They carry signals to the brain for sensation, telling you about touch, temperature, pressure, and pain, especially on the sole of your foot.
Right.
And they also carry signals from the brain for motor control. So they allow you to move all those tiny little muscles within your foot.
Wow.
Hmm.
Yeah, I can definitely imagine with all those nerves running through such a compact area. Things must get pretty crowded down there.
They really do, and that's absolutely key to understanding potential problems. Their pathways are incredibly intricate.
How so?
Well, they travel near or sometimes even through other structures. Things like muscle tendons. The sources specifically mention the flexor digitorum longus and flexor hallucis longus tendons, the ones that help curl your toes down. And they also weave through muscles like the abductor hallucis that moves your big toe sideways, the quadratus plantae, and the flexor digitorum brevis. These are all important little muscles for foot movement and arch structure.
Wow, muscles, tendons.
Yeah.
Is there anything else they're running alongside?
Oh, yeah. They're also closely associated with the arteries. You've got the posterior tibial artery and its branches, the medial and lateral plantar arteries running right alongside them in many places.
Hmm.
There are even specific anatomical landmarks mentioned, like something called the master knot of Henry, which is basically a spot where a couple of tendons cross over and the nerves pass right nearby.
So it sounds like a really busy intersection of all sorts of different tissues.
Yeah.
A bit chaotic, maybe?
That's a great way to put it. Exactly. And the sources point out that even slight variations in this really complex anatomy, from person to person.
Which happens all the time, right?
No, absolutely. Those variations can create areas where nerves might be, let's say, more vulnerable to getting pinched or irritated. And that can lead to this whole spectrum of symptoms when they get aggravated.
Okay, so given how packed that area is, it totally makes sense that things can get squeezed. What does the research say are the main reasons these nerves start causing pain?
Well, the sources seem to boil it down to two main categories, broadly speaking.
Okay.
The first one, and probably the most relevant for a lot of the foot and leg pain people experience, is compression syndromes. Essentially, nerves getting physically squeezed or entrapped by the tissues around them.
Right, like getting pinched.
Exactly. And the second category is metabolic processes. So things like diabetes or maybe chronic alcohol abuse, which can cause damage to the nerves more generally, like systemically.
Gotcha. So if you're feeling pain, it might be a very localized squeeze point, or it could be part of a bigger health issue affecting the nerve tissue itself.
Correct.
Where does this squeezing, this entrapment, happen most often in the foot and leg, according to the sources? Do they give us a kind of ranking?
They do, actually. The research lists the frequent spots, sort of in order of how common they seem to be. Top of the list are the digital nerves going out to the toes.
Okay.
Then Baxter's nerve, which is a branch right on the bottom of the heel. We'll definitely talk more about that one. Then you've got isolated entrapments of the medial or lateral plantar nerves themselves. After that, the main posterior tibial nerve, which can lead to tarsal tunnel syndrome. Then the deep fibular nerve, the superficial fibular nerve, the sural nerve, and finally the saphenous nerve seem to be less common, but still possible sites.
Wow, that's quite a list.
It is. But knowing this gives clinicians a kind of roadmap, right? A list of likely suspects when you come in describing where your pain is and what it feels like.
Okay, let's zero in on some of the specific pain syndromes linked to these nerves then, especially since heel pain is just such a common complaint for so many people. The sources had some really good detail here.
They really did. So one classic example, although it often affects the forefoot more than the heel, is digital nerve entrapment. This is often associated with what people call a Morton's neuroma.
Right, I've heard of that.
Yeah, but a key insight from the sources is that the painful symptoms, that burning or tingling, often come from the nerve being entrapped before a significant swelling, like a true neuroma, even develops.
Ah, okay, so the pain can start before there's a big lump. What would that feel like to someone experiencing it?
Typically, it's described as a burning or maybe electric shock type pain, and often paresthesias, that's the pins and needles or numbness feeling, usually in the web space between the affected toes.
And how would a doctor test for that?
There's a specific test called the Mulder sign. What they do is they gently squeeze the metatarsal heads. Those are the long bones behind your toes together. If that squeeze reproduces your specific pain, or if you feel a kind of click, that's considered a strong indicator of this digital nerve issue.
Ouch. Okay. Now, thinking specifically about the heel, the sources, especially that Podiatry Today article, seem to highlight a really common, but maybe less widely recognized, cause of heel pain.
Yes, this is a crucial insight, absolutely. Baxter's neuropathy. It's the entrapment of the first branch of the lateral plantar nerve, which is also called Baxter's nerve.
Okay.
And it's cited in the literature, including that Barrett article, as being responsible for a really significant percentage, somewhere around 15 to 20% of chronic plantar heel pain.
15 to 20%. Wow, that's a lot.
It is. It means potentially a lot of people who might currently think they just have stubborn plantar fasciitis could actually have this specific nerve issue contributing, or maybe being the main driver.
So if someone listening has had heel pain for ages, especially maybe on that inner bottom side of the heel, it's really important they consider this possibility. Where does Baxter's nerve typically get squeezed?
Yeah, the common spots mentioned are between the fascia, that's the tough connective tissue sheath of the abductor hallucis muscle, which pulls the big toe away,
Right.
and the quadratus plantae muscle, which is a deeper foot muscle, or sometimes it gets pinched a bit lower down between the flexor digitorum brevis muscle, which lies under the arch, and the calcaneus, the heel bone itself.
And what causes it to get squeezed in those spots? Is it overuse or?
It can be a few things. Repetitive stretching of the nerve, which you might see in athletes. Sometimes muscle hypertrophy, just having larger muscles in that area. Bone spurs can do it. Inflammation of a bursa, that little fluid-filled sac. Or even, interestingly, inflammation of the plantar fascia itself could put pressure on the adjacent nerve.
Huh. Okay. And how does the pain from Baxter's neuropathy usually feel? What would someone notice differently, perhaps?
Typically, it's described as chronic pain, located pretty specifically on the medial plantar heel, so the inside bottom part of your heel.
Okay.
It characteristically gets worse with activity, and often it's aggravated by specific foot movements, like eversion that's rolling your foot outwards and abduction moving your forefoot away from the midline. Now, here's a potentially key difference from some other nerve issues. You usually don't get significant tingling, numbness, or muscle weakness with Baxter's neuropathy. It's primarily pain.
That's a really helpful distinction.
Yeah, and a clinician might find exquisite tenderness if they press deeply right over that abductor hallucis muscle near the heel bone. That can be a big clue.
Okay, so Baxter's nerve is clearly a major player in heel pain. Are there other nerves in that area that can also cause similar pain?
Oh, absolutely. Tarsal tunnel syndrome, or TTS, that's a compression of the main tibial nerve or its branches as they pass through that tunnel behind the ankle bone. That can definitely contribute to plantar heel pain as well.
Right.
The medial plantar nerve, one of those main branches, can sometimes get entrapped separately, maybe where fascia binds it down beneath the talus and navicular bones, kind of in the arch area.
Hmm.
And even the medial calcaneal nerve, which is a smaller branch that goes more directly to the skin of the heel, is also documented as a potential source of heel pain if it gets irritated.
Man, it really sounds like diagnosing nerve pain in the foot and leg requires some serious detective work. How do clinicians usually go about figuring out exactly which nerve, if any, is the culprit?
The sources are very clear on this. It really starts with a comprehensive physical examination combined with a really thorough knowledge of the anatomy down there.
So they need to know exactly where everything is supposed to be.
Exactly. The clinician needs to be able to mentally picture where these nerves run, what structures they pass by, under, or through. That's fundamental.
What kind of things are they looking for during that physical exam?
Well, palpation is key. That means carefully feeling for the spot of maximal tenderness. Is it directly over where they suspect a nerve runs? Or is it at a specific potential entrapment point, like over the abductor hallucis muscle for Baxter's, or near the medial calcaneal tuberosity on the heel bone?
Okay.
They'll also perform specific nerve tests. This might involve checking for any loss of sensation on the sole of the foot. They might do a Tinel's test, that's where they gently tap over the suspected nerve pathway.
To see if it shoots pain.
Exactly. To see if it reproduces that electric shock or tingling sensation down the nerve's path. Or they might just see if directly compressing the nerve for a short time brings on your pain or those paresthesias.
You mentioned special movement tests earlier too, right? These
Yeah.
neurodynamic tests.
Yes, and this is where that understanding of how nerves behave dynamically really comes into play. Tests like the straight leg raise, SLR, or modified versions of it aren't just about stretching your hamstrings.
Right.
They're designed specifically to put certain kinds of mechanical stress or movement onto the nervous system pathways to see how they respond physiologically.
How does that help pinpoint nerve pain, say, in the heel?
Well, take that modified SLR test described in one of the sources. By adding ankle dorsiflexion, pulling your foot up towards your shin, and evasion rolling it outwards while keeping the knee straight, and maybe adding some hip flexion.
Okay, that sounds like a specific position.
It is. You're specifically trying to increase the strain or tension on the tibial nerve and its plantar branches down around the ankle and foot.
And the point is?
The critical insight is that studies suggest this particular combination of movements can reproduce plantar heel pain if it's actually originating from irritation of those specific nerves. But importantly, it doesn't seem to significantly increase tension in the plantar fascia itself. So if that specific test lights up your heel pain, it kind of leans the diagnosis more towards a nerve issue, like maybe Baxter's neuropathy, rather than purely plantar fasciitis.
That's fascinating, using movement to differentiate.
Exactly. The sources also note, interestingly, that adding hip flexion during a standard SLR can actually increase how much the nerve has to move or slide higher up the leg in some individuals. It's all connected.
That's really cool. What about imaging? Do things like X-rays or MRIs help in this process?
They can. Röntgenograms, which are basically X-rays, can be useful first to rule out obvious bony issues, like a stress fracture in the heel bone, or maybe identify really large bone spurs that could potentially be pressing on a nerve.
Okay, so rule out the bone problems.
Right. And then advanced imaging like MRI or ultrasound can sometimes help visualize the nerves themselves and the surrounding soft tissues. They might help localize specific areas where a nerve looks swollen or potentially entrapped. Ultrasound specifically is mentioned as potentially being able to detect nerve swelling or even see if a nerve isn't sliding properly during movement, although the sources do note that its usefulness for specific conditions like tarsal tunnel syndrome is still an area of ongoing research. Not quite definitive yet.
Gotcha. And what about those electrical tests, like nerve conduction studies?
Yeah, nerve conduction velocity NCV studies are definitely a tool in the toolbox. But the sources mention that results can sometimes be normal, even when there is a nerve entrapment, especially if the compression is intermittent or only happens with certain activities.
So a normal test doesn't completely rule it out.
Not necessarily, no. There's another type of test mentioned, quantitative sensory testing, QST, which is highlighted as being potentially highly sensitive for detecting problems in the small nerve fibers, even when the standard NCV or EMG tests come back looking normal.
Okay, so it sounds like for someone experiencing this kind of persistent pain, the diagnosis really involves a clinician putting together all these pieces,
Yeah.
your history, a really careful physical exam, these specific movement tests, and then potentially using imaging or electrical tests to kind of confirm and build a clear picture of what's happening with the nerves.
Exactly right. It's about combining that clinical expertise with a deep understanding of this complex anatomy and, all the ways it can potentially go wrong.
This brings us back neatly to that concept you introduced earlier, neurodynamics.
hmm
It really seems like understanding this is key, not just for diagnosis, but potentially for treatment too. Can we dig just a little deeper into what neurodynamics really means? It sounds kind of technical.
Sure. And yeah, it can sound technical, but the basic idea is pretty intuitive. The older term people used was neural tension, but that only really tells part of the story.
Okay.
Neurodynamics is a much more complete concept because it recognizes that nerves aren't just like static wires sitting passively in your body. They are dynamic structures. They are designed to move, to slide, to glide relative to all the tissues surrounding them as we move our bodies.
So it's not just about a nerve being stretched too tight, like an elastic band.
No, it's much broader than that. Neurodynamics looks at both the mechanical and the physiological responses of the nervous system when it's subjected to movement and mechanical stress.
Okay, mechanical and physiological, what does that mean practically?
Well, mechanically, it's about how nerves physically behave during movement. How much do they slide back and forth? How much do they elongate or stretch? How does their actual shape change? How does the pressure inside the nerve fluctuate? And yeah, how much tension are they under during different movements?
Got it. And these mechanical things have physiological effects on the nerve itself.
Precisely. That's the crucial link. If a nerve is excessively compressed or maybe tensioned beyond its normal limits, it can actually reduce the blood flow within the nerve itself. The nerve needs its own blood supply, just like any tissue.
Right.
It can also disrupt something called axonal transport, which is basically how nutrients and essential components get moved up and down inside the nerve fibers. And it can alter impulse traffic, change the electrical signals the nerve is sending or receiving.
Wow.
So those neurodynamic tests we talked about, they're designed specifically to provoke these combined mechanical and physiological responses, helping clinicians identify when a nerve isn't moving or responding normally.
It just makes intuitive sense, doesn't it? If a nerve is supposed to slide smoothly and it gets caught or stuck, it's going to get irritated and probably painful.
It really does. And the research actually shows that nerve movement isn't just a simple, uniform back and forth thing. It's non-uniform. It varies a lot depending on the specific body movement and the local anatomy around the nerve. Well, for instance, during a straight leg raise, the sciatic nerve and its main branch, the tibial nerve, they move and slide differently, and by varying amounts at different points along the leg, depending on the exact position of your hip, your knee, and your ankle. It's complex.
Okay. So if a big part of the problem is restricted nerve movement or altered dynamics, it seems logical that treatments might involve trying to, well, improve that movement, get things sliding again.
That's exactly where neurodynamic interventions come into the picture. Techniques like nerve mobilization, sometimes called gliding, or specifically nerve flossing, are designed with the explicit goal of trying to normalize that nerve mobility, restore the slide, and glide.
Nerve flossing. I love that term. It sounds exactly like what you do with your teeth. Is the concept actually similar, sliding something back and forth gently?
It's actually a great analogy. The basic concept behind nerve flossing technique, or NFT, is to mobilize the nerve, get it moving, but with minimal increase in overall tension on the nerve itself.
How does that work?
You try to create a kind of dynamic variation in pressure along the nerve's path. So you might position the joints at one end of the nerve's pathway to put a gentle tension on it, while simultaneously positioning the joints at the other end to put it on slack or relax it.
Oh, okay. Tension one end, slack the other.
Right. And then you reverse that sequence, maybe rhythmically. So you're essentially encouraging the nerve to gently slide back and forth within its sheath and through the surrounding tissues, hopefully without aggravating it by overstretching.
That sounds, well, it sounds quite promising, actually. Is there solid research supporting this idea for actual painful conditions? Does it work?
Yeah, we looked at a couple of interesting studies on this. One was quite recent, published in 2024. It specifically investigated the effect of sural nerve flossing. The sural nerve runs down the back of the calf on nerve function and pain in patients with diabetic neuropathy.
Okay, and as we said earlier, diabetes is one of those metabolic causes of nerve damage, right?
Yeah.
Often involves that burning, pain, numbness.
Yeah.
It can be really tough to treat.
Exactly, a very challenging condition. So this study involved 25 participants who had diabetic neuropathy. They were instructed to perform sural nerve flossing exercises 5 times a week for a period of 3 weeks.
Okay, pretty intensive for 3 weeks. What did they measure?
They measured two main things. First, sensory nerve conduction velocity, or SNCV, which is basically a measure of how fast sensory signals are traveling along that sural nerve. It gives an indication of nerve function.
Right, faster is generally better.
Generally, yes. And second, they measured pain using a standard visual analog scale, or VAS.
And what did they find after just those 3 weeks of nerve flossing?
They found statistically significant improvements in both measures. The SNCV scores improved, suggesting better nerve function, and the pain scores on the VAS were significantly reduced.
Wow, in just 3 weeks. That's pretty encouraging.
It really is. The conclusion drawn by the researchers was that this nerve flossing technique seems to be efficient in the rehabilitation of these diabetic neuropathy patients, improving both their nerve conduction velocity and reducing their pain levels.
That's great. Any caveats?
Well, they did acknowledge the study limitations, of course. It was a relatively short intervention period, only 3 weeks, and a fairly small sample size, just 25 people. So more research is definitely needed to confirm these findings and see about longer-term effects. But still, very encouraging initial results.
Absolutely. That's incredibly interesting, especially for a systemic nerve issue like diabetic neuropathy. What about nerve pain caused more by that physical compression we talked about, like sciatica? Is there evidence for flossing there?
Yes, we also looked at a 2019 study that did a comparative analysis. It focused specifically on acute sciatica.
Okay, which is often caused by that sciatic nerve getting pinched or irritated somewhere, causing pain radiating down the leg.
Exactly. And this study compared the nerve flossing technique, NFT, to a perhaps more traditional neural mobilization technique, NMT.
How did they set up that comparison? What did the study look like?
They took 30 participants who were experiencing acute sciatica and randomly assigned them to one of two groups. Now, both groups received what they called conventional treatment.
Okay, what did that involve?
Things like cryotherapy, basically ice or cold therapy exercises focused on strengthening core muscles, and advice on ergonomics, posture and movement, standard stuff.
Right.
Then one group, Group A, added the neural mobilization technique, NMT, to their conventional treatment, while the other group, Group B, added the nerve flossing technique, NFT. They did this for 5 consecutive days.
5 days only. Okay. And what did they measure?
They measured pain using a numerical pain rating scale, NPRS, like 0 to 10. And they also measured hip flexion range of motion using the passive straight leg raise, PSLR test, basically. How high could they lift the leg before pain stopped them?
Got it. So both groups got the standard care plus one of the specific nerve techniques. What were the outcomes? Did one work better?
Well, first off, both techniques, when added to conventional treatment, resulted in significant improvements within each group. So both groups experienced reduced pain and improved hip flexion range of motion over that short 5-day period.
Okay, so both helped compared to baseline.
Yes. But then they compared the two groups directly against each other. And for pain reduction, measured by the NPRS, there was actually no statistically significant difference between the NMT group and the NFT group.
Huh. Okay, so for just reducing pain levels in this particular study, the flossing wasn't significantly better than the other mobilization technique.
That's what they found for pain, yes. But here's a really key insight from this study. When they looked at the improvement in hip flexion range of motion, the PSLR measurement, the nerve flossing technique group, showed a statistically highly significant improvement compared to the NMT group.
Wow. So even though the pain reduction was pretty similar between the groups, the people doing the nerve flossing were able to move their leg, their hip, significantly more freely afterwards.
Exactly. That's a really interesting finding. So the conclusion drawn from this particular study was that NFT, when added to conventional treatment, seemed to be more effective than NMT plus conventional treatment, specifically in improving that hip flexion range of motion. And therefore, they suggested it might be considered a better option for managing acute sciatica symptoms overall, even if the direct pain effect was similar to NMT in this short trial. More movement is generally a good outcome.
Definitely. How do the sources theorize that nerve flossing actually works to achieve these effects? Especially that improved movement. What's the proposed mechanism?
Well, the theories mentioned touch on a few possibilities. One idea is that those dynamic pressure variations created by the flossing motion might help to kind of pump out or reduce swelling within the nerve itself. They call it intraneural edema.
Okay. reducing swelling inside the nerve.
Yeah, and by doing that, it could potentially help restore the nerve's normal physiological function. Another idea is that it might directly reduce compression or tension or maybe friction on the nerve by helping it physically move more freely through any tight spots or interfaces with other tissues.
Makes sense. Get it unstuck.
Right. And this, in turn, could decrease the nerve's mechanosensitivity, basically, make it less likely to fire off pain signals in response to normal mechanical stress or movement.
Okay. And the improved range of motion, like in the sciatica study.
For that, they suggest it could simply be because the nerve irritation and pain were limiting the person's ability to move fully in the first place. So by reducing that nerve irritation through flossing, you allow for greater flexibility. It might even feel like it increases the length of muscles like the hamstrings if they were being held tight protectively due to the nerve pain.
Gotcha. So it's not necessarily stretching the muscle, but calming the nerve down allows the muscle to relax more.
That seems to be the thinking, yeah. So while the research is definitely still evolving, these studies provide some pretty interesting evidence that actively mobilizing or, flossing nerves might be a really valuable treatment approach, not just for the pain itself, but potentially for improving nerve function, like the NCV study showed, and improving movement limitations too.
Okay, stepping back a bit then. Beyond these specific neurodynamic techniques like flossing, what are the general treatment considerations mentioned in the sources for foot and leg pain that might be coming from nerves? What's the overall approach?
Well, one thing that comes through clearly is that conservative treatment is almost always the first line of defense. You try the less invasive things first.
Makes sense. How long should someone try conservative care?
The research suggests pursuing these conservative measures for a decent amount of time, often at least 6, maybe even up to 12 months, before really considering surgical options, especially for chronic, persistent cases. Patience is often needed.
And what does conservative treatment typically include in this context?
It includes the types of conventional treatments that were used alongside the nerve techniques in that sciatica study we just discussed. Things like cryotherapy, using cold, specific stretching programs, exercises aimed at strengthening core muscles for better overall support, and also ergonomic advice. That could be about posture, how you move, or even things like footwear recommendations, making sure your shoes aren't contributing to the problem. These standard approaches likely play a really crucial role in overall management.
Okay, and if those conservative measures just aren't enough for someone who has a clearly diagnosed nerve entrapment, what then?
Well, surgical options do exist. These primarily involve surgical decompression, basically, procedures designed to physically create more space for the specific nerve that have been confirmed to be entrapped or compressed.
Right, freeing it up surgically.
Exactly. However, the sources do offer a note of caution here. They mention that the quality of research looking at surgical outcomes can sometimes vary, and also sometimes multiple procedures might be performed at the same time, which can make it a bit challenging for researchers to isolate the precise effect of decompressing just one specific nerve versus another, or versus other things done during the surgery.
Okay. So it can be hard to know exactly what made the difference.
Sometimes, yeah. It just really reinforces how critical that initial accurate diagnosis is, making sure you're targeting the right nerve, the actual source of the problem, whether it's with conservative care or, if needed, surgery.
Absolutely. And it's probably vital to remember, as you said earlier, that while we've focused a lot on nerves here, foot and heel pain can have many, many different causes.
Right.
A good clinician needs to consider a whole range of possibilities.
Oh, definitely. That differential diagnosis step is crucial.
What are some of those other possibilities that might mimic nerve pain or that need to be ruled out?
Well, besides the nerve issues we've discussed, potential differential diagnoses for foot and heel pain that are listed in the sources include, of course, plantar fasciitis. Although, interestingly, one source notably suggested it's perhaps better thought of as a degenerative condition, plantar fasciosis, rather than purely inflammatory.
Interesting distinction. What else?
Things like a calcaneal fracture, so a broken heel bone, which could happen from trauma or stress, a sudden rupture of the plantar fascia itself, or sometimes atrophy, which means wasting away or thinning of the fatty pad under the heel, which normally provides cushioning. These are all issues located right there in the foot.
But it's not always just a local problem in the foot itself, is it? You mentioned earlier that pain can sometimes radiate down from higher up.
Yes, and this is a really critical point that the sources emphasize. Pain that you feel primarily in your foot or your heel could actually be originating from a problem much further up the chain, maybe in the leg or even in your lower back.
Like what kind of problems?
Well, it could be something like S1 radiculopathy. That's where a nerve root coming out of your lower spine, specifically the S1 nerve root, gets irritated or compressed, perhaps by a disc issue. And that can send pain signals radiating all the way down the leg, potentially being felt most strongly in the foot or heel.
Wow, so back problems causing foot pain.
Absolutely. Or you could have compression of the main tibial nerve higher up, maybe in the popliteal fossa, which is that space behind your knee. It could potentially get squeezed by the soleus muscle or even by something like a Baker's cyst back there. So this really highlights why a thorough clinical evaluation needs to consider the entire pathway, the whole limb, and even the spine, not just focus narrowly on the spot where you feel the pain most intensely.
That insight is really powerful. That the pain's address, where you feel it, isn't always its true origin. For anyone listening who's experiencing chronic foot or leg pain, just understanding these different possibilities, including nerve involvement both locally and potentially from higher ups, seems incredibly important for getting the right diagnosis and treatment.
Yeah, I think it really empowers you to have a more informed, productive conversation with your healthcare provider about all the potential factors.
This has been a really, really valuable deep dive into what's clearly a common but, gosh, incredibly common issue. To try and wrap things up, what would you say are the absolute key takeaways about foot and leg nerve pain from all the sources we explored today?
Okay, let's summarize. First, I'd say foot and leg pain, and especially that persistent nagging heel pain, is actually frequently linked to nerve entrapment or nerve dysfunction. It's not always just muscles or fascia.
Right. Don't forget the nerves.
Exactly. And specific nerves, like Baxter's nerve in the heel or the digital nerves going to the toes, are pretty common culprits. Second takeaway. Accurately diagnosing this requires a really skilled clinical evaluation.
What does that involve again?
It's that combination of a careful physical examination using specific clinical tests that assess how the nerves are behaving mechanically and physiologically, and then sometimes using imaging like ultrasound or MRI, or maybe electrodiagnostic studies like NCV or QST to help pinpoint the exact nerve and the likely site of the problem.
Got it. And we also learned about neurodynamics, that crucial understanding that our nerves aren't just static wires. They are dynamic structures that absolutely need to move and slide freely within our body, and this movement is vital for their health and function.
Yes, absolutely. And that understanding directly leads to some of these newer treatment approaches like nerve mobilization or nerve flossing.
Right.
And the studies we looked at, while needing more research, certainly suggest these techniques can be promising. For conditions like diabetic neuropathy, maybe improving actual nerve function and reducing pain. And for things like sciatica, potentially improving movement range, even if the pain relief was similar to other techniques in that one study.
Okay. And the final key point.
I think it's remembering that diagnosing foot and leg pain really involves looking at the whole picture, considering not just the potential issues right there in the foot itself, but also ruling out or identifying potential problems with nerves originating higher up the leg or even coming from the spine.
That holistic view seems absolutely essential.
It really is.
Okay, so here's maybe a final thought for you, the listener, to take away, especially if you've been dealing with this kind of persistent foot or leg pain. Given everything we've discussed about how much our nerves need to slide and move freely for us to function without pain, perhaps thinking about the dynamic needs of your nervous system itself, not just focusing on the strength or flexibility of your muscles and joints, offers a slightly different and maybe potentially helpful way to approach understanding and managing your pain. Something to mull over.